this week's office. Thank you so much for joining us for this week's office hours meeting. As usual, for the CalAIM Reentry Initiative Learning Collaborative office hours, your microphone will be muted while we are speaking and going through the slides that we've prepared for today. You can use the Q&A feature to ask questions, and then when we open it up, you can raise your hand to share live feedback or ask questions. We'll do our best to answer all of the questions that we get today. And as we typically do, we prepared some slides that will walk through the questions that we received in the prior week's Learning Collaborative session. This is our final office hours for the year. So just wanted to say thank you again for all of you for coming to these office hours sessions and our Learning Collaborative sessions. We hope that these have been super helpful. And we plan to continue into 2025 with a new set of topics. Let's go ahead and get started, and we'll jump into the next slide and the next one after that. So we've done a lot together, and we talked about this last week during the Learning Collaborative meeting, but just in case you weren't able to join us last week was the last of our first kind of phase of the Learning Collaborative series. Part 2 will start in 2025. We do plan to send out a survey to get your feedback about the Learning Collaboratives, not just the ones that have happened so far and how we can improve things going forward, but we're interested in hearing from you topics that might be of the most interest to you all. For example, we know that there will be updates to the policy and operations guide in January, so we'll be walking through that at an upcoming meeting. We know a lot of our youth correctional facility partners are interested in the Consolidated Appropriations Act. More information will be coming about that, and we may want to revisit some of the other topics that we dealt with in the first part of the Learning Collaborative series. So we might revisit the screening portal because we know we continue to get a lot of questions about that, or behavioral health links, for example. And we'll definitely want to revisit care management, ECM, and warm handoffs. So there will be some additional topics and additional opportunities for dialogue and discussion, but we really appreciate you coming on this journey with us. Let's go ahead and jump in, and we'll go to the next slide, which is the first question. So we get a lot of questions about SUD screening tools, and I know last week we got this question too, but wanted to kind of start here. We will not endorse a particular tool at the Department of Healthcare Services, but any clinically validated assessment tool is eligible. You can use any clinically validated tool. And we did provide some examples of acceptable SUD screening tools that might be used in a correctional facility setting. We're not saying you have to use one of these or that any particular one is preferred. We do just expect you to do that screening for substance use disorder using a clinically validated screening tool. So any of those tools are acceptable as examples. Next. We also get a lot of questions about the ASAM assessment requirements, or the American Society of Addiction Medicine ASAM requirements. So for people who screen positive using a clinically validated SUD screening tool, it is expected that the ASAM criteria assessment, which is linked in the deck and will be shared with you all, is used to determine the most appropriate clinical level of care. The ASAM criteria assessment tool is really about identifying level of care and placement needs, and that's for both pre-release and post-release. So if there's a positive screen for potential substance use disorder, then the next appropriate step would be to use the ASAM criteria assessment tool. We also expect all incarcerated individuals who screen positive for SUD and have stays, so their incarceration duration is 30 days or more, that the ASAM criteria assessment is completed for those individuals, and that as part of the reentry planning, the pre-release care manager updates the ASAM criteria assessment so that the post-release care manager has the information necessary for post-release level of care, including residential treatment, and can secure those options when that's the appropriate treatment option for the individual based on the assessment. Next. We also have gotten a lot of questions about the prior authorization process for a Medi-Cal RX and for our Medi-Cal drug formulary. So for drugs that are not on the formulary and require a prior authorization, those prior authorization, if there's a prior authorization active in the Medi-Cal RX system from the individual's, caregiver prior to incarceration, then that would mean that the claim would be paid without an additional authorization needing to be requested. So if you submit a claim to test whether the drugs have been authorized, if there is a current authorization, the claim would be paid. If there's not a current authorization, the claim would be rejected pending a prior authorization for that drug. And so that's really the process. The prior authorizations are associated with the NPI of the original submitter, and so you wouldn't be able to see the prior authorization in the system. But if you submit a claim for that drug, if it's been previously authorized, then that claim would be paid, even based on the based on the previous prior authorization. And so that would be one way for you to know. Next slide. A little bit more on prior authorization, kind of questions about whether the PA could be submitted retroactively. And yes, that can happen. The PA will need to be submitted prior to the claim being paid, but can request a retroactive date to the date of service as part of the prior authorization process. Next. So we've gotten a lot of questions about the MOU requirements for correctional facilities and managed care plans. DHCS is working on a boilerplate template for the MOU. As we've said previously, just reiterating today, we do not require the execution of the memorandum of understanding as a prerequisite for go live. So we have the 3 counties that went live in October. They do not have necessarily the MOU in place. We haven't released the MOU yet. We will expect that all correctional facilities and managed care plans do execute the MOU once the template is formally released, but we will put it out for public comment before we issue it formally. We plan to release it for public comment in the first quarter of 2025. Then we'll take all of the feedback that we get from our correctional facility partners or our managed care plan partners and release the final template by July of 2025. And then at that point, we would expect the managed care plans and correctional facilities to work together to start to put that MOU agreement in place. Of course, even without a memorandum of understanding formally through DHCS's template, it is the expectation of the department that managed care plans and correctional facilities are working together collaboratively to ensure that you're planning your processes together, that the correctional facility is getting information from the managed care plan about how the enhanced care management benefit will roll out for that particular plan or the plans in that county, and that the managed care plan is got information from the county correctional facility about their proposed go live, and they're starting to work together on formulating the strategy for how that partnership will work, and how it will be spelled out in the MOU. Next. I know that there continue to be a lot of questions about meds in hand. And the most recent question that we got last week is about what happens if a correctional facility releases an individual with the remaining medication in a current prescription, and would that meet the meds in hand requirement? So maybe it's not a full supply, but they have a recent prescription and they leave the facility with the medications in their current prescription. That would not fully meet the requirements of the special terms and conditions of the waiver, as spelled out in the policy and operation guide, because the requirement in the waiver and from a federal perspective, as well as from the state, is that individuals are released with a full supply of medications in hand upon release. So a partial uh, uh, a supply is not meeting the expectations outlined in the waiver or in the policy and operations guide. A full supply is the maximum amount that is medically appropriate and permitted under the Medi-Cal state plan, which under most cases is a 35-day supply for controlled substances and a 100-day supply for other prescription drugs. If the individual's remaining medication is not a full supply, the correctional facility must ensure that a full supply of the medications are provided to the individual upon release. And in addition, the correctional facility should submit a prescription for any active medication, formula, or medical supply to a community pharmacy as appropriate and feasible so that the individual has access to refills. You can also work with the post-release ECM care manager to make sure that that's happening, but it is a responsibility of the correctional facility. Next. In terms of data sharing, we wanted to raise to your attention that DHCS recently released a data sharing authorization toolkit for the reentry initiative specifically. That is out for public comment now. We will put the links in the chat to make sure that everybody has access to that tool. Comments are due to DHCS by January 8th. And in that guidance document, there are many different scenarios that pose kind of what are the considerations and questions you must ask about data sharing with that entity. And so we would suggest that you all review that data sharing toolkit and provide comments on it if you have further questions, but also review it for guidance in terms of when you can share data with community-based organizations and reentry providers, what the expectations are for data sharing. All of that is spelled out in the Reentry Initiative Toolkit. We also will plan to go through data sharing specifically in a focused learning collaborative in 2025, and we'll invite our teams that worked on the data sharing authorization guidance around the reentry toolkit to participate as subject matter experts so that you have the right people to answer those questions. But for all of your data sharing authorization questions, we would point you in the direction of that toolkit and ask for your comments and feedback if you have any. Next. All right, so I'm going to turn it over to our team from Santa Clara County. We did get some questions from our Q&A during the last session for Santa Clara specifically. And so we're going to ask our Santa Clara County team to come in and address the questions that you see on the screen. I'll invite our Santa Clara colleagues to join us.
Everybody. My name is Allison. I'm the pharmacy supervisor for our custody health pharmacy here at the county. And also on this call is Fatima. Fatima, do you want to introduce yourself as well?
Sure. Hello, everyone. My name is Fatima Magzoum, and I'm our EMR IT project manager for the CalAIM project.
Okay.
Uh,
Do you want to address the first two questions, Fatima, and then I can address the third one?
yeah, so I can take, yep, for the first one. So we have a JMS system that does directly integrate into Epic, which is our healthcare EMR. And when a patient is first admitted into custody during intake, a nurse or a MUC will first try to look them up in Epic. And then if they don't already exist in Epic, they will create them as a brand new patient and create an incarceration admission. On the same time, someone from the sheriff's office will be admitting the patient into our JMS system. The nurse will take the MRN and a admission specific contact number, which we call the CSN, and they will manually input them into CJIC, and which is the JMS system, and that creates the link. And once that link is established, then we do have messages sent over to Epic whenever there's any sort of patient movement. I think that addresses the question. Is there any further follow-up to that one?
Let's see if folks, anybody wants to raise your hand at this point to ask follow-up questions. Feel free to do so. I'm not seeing any follow-up questions in the Q&A, but if you're willing to take live questions, then folks can raise your hand if you have follow-up questions for that response. Not seeing any hands raised. All right, thanks. Let's go ahead and go on to the next one.
So for question number two, it does sometimes occur that the patient will be duplicated in Epic or EMR. It might be because maybe we don't have their social security at the time, similar names. So if we do happen to create duplicates on the Epic side of the house, our health system HIM department actively manages these just as they would if patients were coming into the hospital. So they will, the system will automatically flag any potential duplicate clients, and then our HIM team will merge. Similarly, nurses and MUCs do have the ability, if they notice some issue or multiple client names, they can directly send a message within our Epic EMR to the HIM team for them to merge those duplicate accounts. Any
Okay,
questions
any
there?
follow-up questions there? Folks can feel free to raise your hand. Not seeing any follow-up questions. All right, question 3.
Okay, so for question three, in addition to NDC not covered, other rejections that we've gotten for our claims is the DUR rejection. So there was a scenario where a patient had received a 90-day supply of a medication prior to being incarcerated. So when we tried to do the adjudication for the 90 days or for the short amount of time that they were incarcerated, we weren't able to submit that claim. We do have an error queue that keeps track of all of these adjudicated claims that don't go through. And we do have a Medi-Cal SME on our team. So typically when we do get these rejections, it flows into that queue, and whoever is working on the adjudication queue will defer any questions on overrides and these situations to her. Another rejection that we get is missing or invalid dispense as written. And then lastly is the prior authorization required. We're still working on how to address the prior authorization workflow, but we've only had a handful that required prior authorization. I'd say the most common ones are that dispense as written or the DUR rejection.
All right, any other questions, or anybody from DHCS's Pharmacy Benefits Division, or other folks from our Medi-Cal Rx team want to address anything else about claims rejections?
I don't know. Let me see here. PBD team, is there anybody that has any additional information to share on that point?
Hey, Erica.
Okay, if there's,
it's Paul.
oh, go ahead, Paul. Thank you.
Yeah. Yeah. Regarding those rejected claims, it sounds like you already have a queue, and an SME. So then, are most, if not all of those rejections able to be processed by that SME? So the one about the DUR, I'm 99% certain the SME knows is that can be overridden at point of sale. And so it's just a matter of submitting the right clarification codes as one example. So are there any that require additional work that they can't just handle through the POS system?
For the DUR rejection, yeah, we were able to get that resolved. For the missing or invalid dispense as written, this was something I encountered recently, so I haven't been able to bring it back to the SME yet. And then for the prior authorization, we're just trying to establish the workflow for how we're going to submit these and who is going to be submitting these. So we haven't actually submitted any prior auths yet.
Understood on the prior question. Thanks.
Okay. All right, well, thank you so much to both of you for jumping in and sharing your experience again. I know that was super helpful last week to kind of hear what you've been experiencing and to come back today and answer some of the questions that folks had for you. We really appreciate the time and effort that you're taking to help educate your colleagues and to interact with us and to kind of work through some of these learnings together. Just really appreciate your continued support of these overall learning collaborative sessions, office hours, and just contributing overall to the statewide learning that we're all doing together on this. We, uh, if there are no other questions specifically for Santa Clara at this time, we'll transition into the open forum Q&A. Thank you both for joining. If folks have other questions about our pharmacy policy or any of the other things that we've shared today or last week, please feel free to raise your hand or answer or address those questions in the Q&A. If there's any additional questions for Santa Clara, we can direct those back to the Santa Clara team. But do appreciate you all being here today. While folks are gathering their questions, I will share the one question that we have so far in the Q&A, which is, can you share more about what to expect for the content of the MOU? For example, as a use case, this San Francisco does not yet have a data sharing agreement with Kaiser. They're starting to look at drafting a data sharing agreement, but maybe it makes more sense to wait for the MOU template to come out if data sharing would be included in that. And so what I'll say is that the template will have a place for managed care plans and correctional facilities to spell out their data sharing agreements. So it could all be included in that template, as well as specifying data elements that are subject to those data sharing agreements as part of the MOU template. The work that you need to do to kind of draft the agreements and get to some agreement about roles and responsibilities will still need to be done, because what the MOU template will do is kind of direct you to add information based on the specific arrangements and agreements that you've all made. It won't spell out specific requirements for data sharing, other than what's required as part of the policy and operations guide. So the specific mechanics of data sharing and roles and responsibilities and all of that will need to be worked out between the managed care plans and the correctional facilities. And again, I would invite you to take a look at the data sharing reentry toolkit that we put in the chat, because that will also help you kind of understand what types of information you will need to add to the MOU template when you execute that for, or a separate data sharing agreements. We also did get another question asking for materials. We will make sure to make those available. I know last week we posted all of the materials or recordings from the prior sessions to the chat. We're working on getting those posted to our website, but we can make sure that we repost them, if that's not too much trouble, team. If we could repost the links to all the recordings from the prior sessions, that would be great. We also got a question about care coordination services that are available for specialty mental health services and DMC, ODS, or drug Medi-Cal organized delivery system clients under PathJI for BH providers to bill via short doyle. So I would just reiterate that for individuals who are incarcerated and for pre-release services, with the exception of the county behavioral health agency receiving the link for a BH link, all of the other care coordination and clinical consultation services must be billed through fee-for-service and not through the short doyle Medi-Cal billing system. Only the receiving of the link, and there's more information on that in the policy and operations guide, but only the receiving of the link is able to be billed through short doyle. We can provide some additional information in the chats or in the Q&A. There's also more information in the policy and operations guide. Anything else that folks want to add on that question about the short doyle billing piece?
Hi, Adam. Thanks for that explanation. This is Megan with Placer County. So we've looked at the policy and operations guide and we need more direction what to bill short doyle for that receiving of the behavioral health link. It's not clear to us.
Okay, we are updating the P&O guide right now. So when the update comes out in January for comments, it will have a bit more detail there, but understood. And is it more that you are looking to have more specific detail about like how to operationalize that, Megan?
Yes, we don't see what the coding is to bill. I think our program manager, who
Jeff.
unfortunately couldn't be here today, was thinking that it was the care coordination or clinical consultation codes that we would bill. But those say JI no on Medi-Cal's list. So we don't know
Those would
what
be billed
codes
to
bill.
fee for service.
Hmm.
So those would have to be billed to through CAMUS to our fee for service delivery system. They would not be billed via short doyle. Like, so we know that that's a change. We will we can plan out a specific county BH specific session on the billing piece in 2025. But that's the reason it says no, is because those codes are not eligible to be billed through short Doyle. They have to be billed through a fee for service through CAMUS.
Right. That's our understanding. So it does not appear that we have coding to bill Short Doyle for receiving the behavioral health links yet.
Ashley, do you have anything to add on that?
Yeah, so all the codes in that service table are the codes that you're eligible to bill via Short Doyle for receiving the behavioral health link. Any other codes that you don't see in there, those would have to be billed via CAMUS fee for service, which is separate from Short Doyle.
Can you be any more specific? Which one is the code for receiving the behavioral health link? That in the mental health side, because care coordination and clinical consultation, I'll say JI no.
So you're referencing the Short Doyle table. So those specific codes for care coordination and clinical consultation are not billed via Short Doyle. Those have to be billed via CAMUS fee for service.
Is the only way to bill for receiving a behavioral health link fee for service then?
No, it's typically Short
Okay.
Doyle. I think there
Okay,
might be some
which codes
confusion.
specifically? Yes.
What do we can circle back with you, Megan, and like I said, we can do a webinar on this specific topic in 2025, but we'll circle back with you specifically prior to that.
Great, thanks. I've emailed that into the Justice Involve distribution list.
Great, thank you. Emily, see your hand.
Yeah, hi, Emily Parmenter from Contra Costa. I think similar on to that topic from Megan, our behavioral health agency is physically located inside our juvenile, well, some staff members are located inside juvenile hall and are providing essentially pre-release behavioral health services today. And just one point of confusion has been sort of how to think about them for the future when we go live with pre-release services. And like while those providers are part of the county behavioral health agency, our thought process has been that while they are physically located in custody providing pre-release services, they would be billing through the fee-for-service system. And then if any of them are providing post-release services, they would bill Short Doyle. Is that like, it's almost sort of a carve out for that physical location, regardless of the fact that that's a staff member of the county behavioral health agency? Is that an appropriate thought? Like, is that, are we on the right track?
I mean, that they would bill fee for service for any of the clinical consultation, behavioral health services. So any of the treatment services that are happening while the individual's in custody during that pre-release period would need to be billed through the fee for service delivery system. And there's also other nuance there if depending on the arrangement that you have at the correctional facility. So if you have a contract, for example, with a correctional facility or through an interagency agreement and they're paying you for those services in a different way, then they could bill for those services and then just pay you against the contract. So you would be an embedded provider in that respect. But as an in-reach provider, you would bill those services to the fee-for-service CAMUS delivery system.
Okay, thank you. That's helpful.
Yeah. Okay, we do have a question in the chat or in the Q&A. I'm going to read it out and then maybe if we can have some of our folks help with this. Can you share what the requirements for pharmacy Medi-Cal enrollment are under the setting of a juvenile correctional facility having a pharmacy license to give out meds under county behavioral health services, but no pharmacy on site? It's in the Q&A team if you want to read it there. Erica, is that something that your team can jump in?
I think provider enrollment would be helpful on that one if they are available.
Okay, I'm not sure if we have any of our provider enrollment folks, so we might, Bernadette, we might take that one back.
Okay, thank you.
Thank you. We can follow up with you though. Okay, any other questions? There's a question about whether there's a list of county behavioral health link contacts, about where to send the behavioral health link referral. We're having some conversations about that and posted on our Justice Involved Resources page on the DHCS page. There is a link to the county behavioral health agencies, provider rosters, so you have that information linked on our page. We can put that link in the chat as well. And then we're having some separate conversations about that. We know some of our colleagues externally are thinking about that as well. So appreciate the question and the ask, and we're trying to think about how to make that information more readily available. Gail?
Hi, I have a question about the third care management model that that you all are offering. That's the mixed hybrid. So CDCR is planning to go live February using that model where some of the pre-release services would be carried out by the ECM JI provider in the county where the client is reentering. And how does billing work for that? If if somebody's reentering in LA County, and the ECM JI provider is doing some of the pre-release services, like arranging the warm handoff meetings or requesting the behavioral health link, how do they get paid? Do they? Yeah.
So there's two ways. One is to have a contract with the correctional facility as an embedded, and then act as an embedded provider. The correctional facility submits the claims for services provided by their embedded then case manager and pays the ECM provider as part of their contract. Or two, enroll as a fee-for-service provider and bill CAMUS for the fee-for-service claim.
Thank you so much for that.
Yeah, and we're, I think, still working on the fee-for-service enrollment pathway for ECM providers, but expect that to be completed in early 2025 is my understanding. But those are the two pathways. Have a contract with the correctional facility or enroll as a fee-for-service provider. Okay, any other questions for today? Not seeing any more Q&A questions, not seeing any more hands raised. In that case, we're going to let folks go a little bit early today. Appreciate all of your questions and your